Hello, everybody. Good morning, afternoon, wherever you're at. And this is exciting because these proposed COPs have been around the block once, clear back in 1997 originally. And they never did get published, but this time I think they're going to go. We were actually debating about that before the call started, and I said, I'm sure they're going to go, and I don't think they're going to drag it out 3 years this time. So if you had a glimpse at them, you'll see that there's a lot of emphasis on the patient care and the quality of that care. So it is all about quality. You'll see that string run all through the different COPs that we're going to talk about today. They only have 3 years to actually finalize this, so that's the maximum, and this came out in the fall of last year. So they've got 3 years from them, from 10/9 actually, to get this thing final. I hope that some of you actually have had a chance to look at those proposed COPs and maybe even provided some comments back to CMS. There are definitely some things that I commented on. One thing was that they wanted times on physician verbal orders, and we don't always get those, and so just little things like that. So we'll talk about the different areas of risk and the different areas that I think are great improvements. And the big focus of today's call is just to get us all familiar with what's coming and to see how can we apply that in our daily operations right now. Because certainly we're not going to change any forms and do things like that quite yet until we know what's really going to happen. But I do think that there's a lot of processes that are excellent standards that we can take on right now and begin to implement these, so that way when implementation finally does happen for these and they do go live and final, we're not bombarded all at once and it's not quite so overwhelming. So let's just talk through the history a little bit. So we know that in 97, they did a complete overhaul in the proposed rule, but as I mentioned, that never did get finalized. The only portion that did is they had to actually put some information in the COPs about OASIS, because OASIS was going live, and that's one reason that they didn't finalize the COPs, because there was so much going on right then in the home health industry. We thought a couple times since then that we were going to have overhauls, but they haven't happened. But in 2011, we did have new survey protocols enacted. So I hope you're all familiar with those protocols, because it is like having the test before we have to take it. It's fantastic information. They provide for the surveyors the step-by-step instructions on how to do a survey, including probe questions, what documentation to ask for. So having that is such a huge benefit to us as agencies, because we can put ourselves through those phases and see how we would do. In fact, I always recommend to have yourself a binder and have the rules in it. Make sure that it's not just stashed away in the administrator's office, but everybody knows where they're at. It's hands-on. And I encourage you to go through them together as a team and talk about how you meet those different standards. I think sometimes it's nice to hear all of the clinicians' point of view, because there are many times that they're helping us meet the standards that we might not have even thought of. So to get that down on paper, to be able to jar our memory when you're sitting in the hot seat with the surveyor, is a great idea. So these proposals, which came out in October, on October 9th, allowed, of course, a comment period. And they actually extended that comment period so that way it went into January because of the holidays, giving us a little bit more time. But that now has ended. But, of course, at the bottom here is the URL for the proposed COPs. If you want to take a peek at the entire document for your reading pleasure, about 300 pages. So the focus of the changes, as I mentioned, CMS has stated that they are patient-centered, data-driven, and outcome-oriented. So it is supposed to really be focused on the patient and the processes that keep our patients safe and provide the best care. So they're very in tune with processes and not just individual circumstances as much. And if they find an individual circumstance, they're going to look back to that process. The overarching new requirement that I'm seeing is that QAPI program. So those of you who also do hospice, this is not going to be a big deal. In fact, perhaps you've already implemented a QAPI program. A lot of us have. But if you haven't, this is a little bit different than just your normal QA. This is ongoing quality assessment that leads into our performance improvement. And that is a key that we want to grasp, because the quality assessment is done at all agencies. Everybody is doing chart audits. Everybody's looking at OASIS. But what do we do with that data? Are we trending it? Are we looking at where are our issues? Where are our risks? Are they with a topic? Are they with a clinician specifically? And so that's what we need to know in order to do the performance improvement piece. So that is actually so logical, isn't it? So don't be afraid of the whole word QAPI and wonder, oh no, does this just mean more work? Because in the long run, it more than pays for itself. So it's really emphasizing that we as an agency are going to provide for our own improvement, and we're not going to just depend for when a surveyor walks in or when we do a quarterly audit. But the QAPI program runs 24/7. It really does work all the time. And if we would go in and ask any clinician in your agency, when we ask who does QA, their answer should be, we do. Because it's not just that QA coordinator who's going to do the QAPI program. We're all responsible for that piece. They did mention, CMS did mention that they took the prior public comments from 1997 into consideration, because some of this information was actually proposed in that prior proposal. So they took those public comments into consideration before this proposed. They added some processes that were what they felt were going to be very patient and process-oriented, that were predictive of desired outcomes, not income. They're predictive of desired outcomes for our patients. And they retained those processes they thought were supporting those good outcomes. But then they also eliminated some things that they didn't feel were direct correlations to good patient care. So let's go through these 5 bullets are straight from CMS, right from their comments, their prelude, if you will, to say what did they want to focus in on. They are looking at that integrated care process across all aspects of home care. Again, based on the patient-centered assessment, and this is the nursing process, the assessment, the care planning, the delivery of service per that care plan, and then the last piece that they're adding is, again, the quality assessment and the performance improvement based on that. They want us to use patient-centered and an interdisciplinary approach. So the patient's always in the middle, but the team is surrounding them. That's where we're supposed to be, and so the COPs support that. They really stress quality improvements by, again, looking at data and assessing where are those needs and then putting plans into action. So, and I think that's the part that we miss many times in our industry is, again, we look at the data, but we don't connect the dots. We don't do things with it. So this is going to push us to that next level. And lastly, they're wanting to 2 more, eliminate the focus on administrative process, which we're all good with. That sounds fantastic to us, doesn't it? If it's lacking the consensus or evidence that it doesn't really impact patient care, they're getting rid of it. So I think that's great. And then lastly, safeguarding patient rights. So the patient rights section, as you'll see here shortly, is really expanded. It does have a lot more meat to it and a lot more details. So let's talk about the things that they're removing. They're going to remove, or they're proposing it anyway, to remove the Professional Advisory Committee, or what we call the PAC meeting. They're looking at removing the annual review, which we usually do with the PAC meeting. And this is going to be replaced. The whole idea behind why we don't need those 2 things is we're going to have daily, we're going to have ongoing QAPI. So we don't need to just review once a year. We're going to be doing this on an ongoing basis. They are removing the verbiage about staff complying with accepted professional standards, and they're getting down to more details. They're modifying it by actually including current practice standards in the COPs. They're proposing that we can get rid of the 60-day summaries to the physician. Now this one I'm not sure of. This one to me I think is a great piece of our coordination of care. So I'm not sure why they're removing that. And lastly, the evaluation quarter that we do of our charts. And again, this comes down to if we're doing COPs, we're reviewing far more frequently than just on a quarterly basis. So instead, that's what we're going to do, is the COPs, that continuous improvement. And really, we're already following behind a lot of other provider types that have moved to this type of strategy. And they feel that the new COPs are going to enable surveyors to look a little closer at our outcomes and ensure that patient care is relevant. So we're not just following the plan of care, but the plan of care makes sense for the patient. And they're going to really focus on the patient's individual needs and make sure, does this all match up? Our assessment should lead to the plan, to lead to the treatment. So again, back to the nursing process here. They're going to remove the focus from services and processes in place. So again, always going back to, is it patient-centered? That's where they're going to want us to focus. As I mentioned, they've expanded the patient rights. That's a big part of the expansion here. And they are adding the discharge and transfer summary and those time frames. So lots more details about that. The PAC will be going away, but the governing body involvement and the accountability of that governing body is also being increased. Now, overall, if you have looked at the COPs, you'll notice first off, just at a glance, that they look different. They're structured different. That's because they've grouped all the COPs directly related to patient care into one large group. And all the regs that are concerned just with the organization as a whole or the administration is grouped into a separate group. So there's actually 3 sections now is all. The first one, A, is general provisions. So that includes things like definitions, and we'll look at a few things that have changed in that area. We're going to spend the bulk of our time today in patient care, and then, of course, we'll touch on the organizational environment. Now, many of these have taken current standards and combined them into a new COP. For example, the current standard of coordination of patient services combined with acceptance of patients and plan of care, along with medical supervision, those were combined to create one COP, which is now 44.60, which is called Care Planning, Coordination of Services, and Quality of Care. Do note that that second one, the acceptance of patients and plan of care, that is the #1 COP cited across the nation. So again, lots of information will all be in this new COP, the Care Planning, Coordination, and Quality of Care. So here's a picture of all of those pieces. Subpart A, general provisions, again, basis and scope and definitions. That's all there is. It's like an intro, basically. Patient care is where the meat is. And I have highlighted by underscoring and putting in italics the 2 brand new COPs. So certainly there's been a lot of changes and overhaul in the COPs as a whole, but these are the 2 brand new ones that we've never had before in home health. And that, of course, is the COP about COPs and is a COP about infection prevention and control. So that has always fallen under the standards of practice and professional services, but now they have their own COP for it. The last subpart, of course, is the organizational environment. So again, the compliance with those laws, organization administration. The clinical records still do fall under here, and of course part of that is the security of them, and then personnel qualification. So let's start with general provisions. So again, under this is our Part A, our Subpart A, and there were just a few changes that I want to highlight here. The first one is that if you have a subunit, which not very many of us have subunits, this is not a branch. This is just a subunit under your original Medicare number. Excuse me. Subunits will be discontinued. So existing subunits, if you do have one, you can put in an application to become a branch, but only if your parent agency is providing supervision and administrative control of the branch on a daily basis. So you want to see how far away are you? Is it reasonable that we can really provide that oversight? Are they really in control and in tune with what's going on for the day-to-days? This needs to be dependent on the parent agency to meet the COPs. They can't be a completely independent entity, or they are not considered a true branch. Now, they are removing the language about sufficiently close, but right in this proposal itself, they said they're removing that, but yet the understanding remains. So we still have to go to the state to ask them if we can have a branch, and then they have to approve if they think it is sufficiently close enough that we can really provide that oversight. They also made some changes in the definitions portion of this general provision, and the first one is about the representative. They have made really clear that it's all about the patient in here. And they will allow the patient to choose whomever they wish to be their representative. So this is, again, part of ensuring that the patient's in the center of the care plan, has the right to choose who they want with their decisions. Now, in this verbiage, it does recognize, of course, that there are patients that have legal guardians and will recognize that if they have one. But otherwise, it is up to the patient. They do basically add an asterisk, if you will, and they say, if you as an agency, if your staff sees that this patient's representative that they have chosen is not performing the functions of a representative, or if you feel that this is not in accordance with the patient's choices, then it says we're supposed to make a referral to the appropriate agencies or authorities. So again, patient rights, protecting patients, which is woven throughout here. They do provide a little bit more clarification on verbal orders. They said that verbal orders are when the physician orders are delivered verbally by the physician or the nurse or other qualified medical personnel recorded in the plan of care. And that would be for establishing my plan of care or updating my plan of care. I think this came about because, unfortunately, as an industry, we kind of told on ourselves to CMS. And when the OASIS items came up about, are these best practices in our plan of care, we just put them on the 485. And they said, well, when do you get the order? And they said, well, we send it to the doc and he signs it. That's not going to be adequate. So they're reminding us that we have to have an order prior to services being delivered. And that's typically done in home care by a verbal order. So be sure we have that verbal order documented. We've talked to somebody and who that was. They also go on to define quality indicators. And they say that they have to be specific, they have to be valid, and they have to be reliable. So then they go on and they talk about different things we can actually measure. We can measure access. We can measure the patient care's outcomes. We can measure their satisfaction, which of course our HCAPS does that for us. And we can measure processes. Now, a lot of this is already being done through the OASIS. The care outcomes is done. The access through timely initiation of care is actually done. Satisfaction through HCAS and the process measures. So all of those best practices, like in the grid of M2250, doing those standardized assessments, those are all process measures that despite the patient outcome, we can show at least we did the right things up front. And they provided this definition related to COPs. They wanted us to use this type of thinking and definition when we developed that COPs program. All right, so that does it for the first section. Second section, patient care. The first standard under patient care, the first COP actually, is reporting oasis. So they updated this section just because they had old language in there, because remember, this is from 1997, between 97 and 99 when they actually did get this finalized, and they had information about dial-up and a phone line, and of course that is not how many of us transmit anymore. So they said now, transmission according to CMS policy. And of course we all know with our semi-painful transition, we're into the new system, which is a national system of ASAP. ASAP is the new system we're using as of this year. Under patient care, the second COP is patient rights. You can see the current standards on the left. We have 6 current standards and 6 proposed standards. So they have shortened the lingo here a little bit, but there's a lot of changes underneath, and we'll look at each one of these to see what has changed. So Standard A, the Notice of Rights, of course, we think of our admission pack, and then we have to give them this in writing and tell them, here's your rights, here's your responsibilities, phone numbers, etc. The current standard basically just says we have to provide this notice in advance. The proposed standard says that, and it goes on to say it needs to be in the language in a manner that the patient understands. This has been an ongoing evolution, especially with the whole patient understands piece. Remember all the directions about our other government forms like the ABN and the HHC-SPN. They're really deliberate to say don't use Medicare-Ease, don't use jargon, don't say homebound. Because we know if we asked anyone sitting around your table, we might all have different definitions of how to document homebound. So if we still haven't decided how to make that look, we don't expect the patient to understand that. So make sure that it really delineates out in a way that is in layperson terms, very simplified. They went on to also say that we should also provide forms that are accessible to patients with disabilities, and we should provide them with auxiliary aids if needed. Now, they do mention that that representative, again, they say it's whoever the patient chooses, can act as a liaison between the patient and the home health agency. So, again, does not need to be a legal representative. It's whoever the patient has designated. We could choose to use an interpreter, and we can certainly provide one, but if the patient has a family member or friend there in the home, that works fantastic too. Now, the written notice of rights has to be provided, so of course in your admit pack, but it goes on to say not just English, English or preferred language. Then they go on to say alternate formats for persons with disabilities, which again, large print, maybe even Braille. They do say that the agency must provide a business contact. So highlight or circle this. This is something that I think we could start doing right now. Provide that business contact, not her cell phone or home phone, but the office number for the administrator. And to put your administrator's name. This allows your patients and caregivers direct access to that home health administrator for concerns, questions, or complaints. So you may want to include 2 numbers, one for the scheduler and one for the administrator. Otherwise, of course, you've got your number on that front of that folder, And we can just put that administrator's name if that's her work number also. We are to provide a copy of the OASIS privacy notice, so that's no change. And we have a URL here for you about that. And then lastly, we have to obtain the patient or their representative signature confirming that the notice of rights was provided and explained. So that's no change. The next two standards under patient rights, standard B and C, we have exercise of rights and respect of property. And then under proposed standards, we have two. Right now, actually, we just have one standard, exercise of rights and respect of property. These two proposed rights go under that, exercise and the rights of the patient. So the exercise of rights just says that it notes when the court decides the patient's incompetent and recognizes that they could have an appointed rep. And then the keys are patient choice balanced with patient safety. Again, verbiage about they have the right to always choose who they want, but if we see that that person doesn't have the best intentions or the patient's needs in mind, then we need to take action. But under the rights of the patient, there are 12 specific rights. So it gets into far more detail than our current regs do. But I'm sure that this is going to be very reflective of what you have in your current patient rights handout anyway. Just double check this. This is something, again, you can do right now. Look at what's proposed here. See if your current patient rights form matches up with all these. Property and person will be treated with respect, free of abuse, etc., etc. So those are very similar to what you see now. Now look at number 4. Right now, this is a level 1 or a tier 1 in our protocol for survey right now. This is something that they look at on a standard survey. Is the patient involved in the plan of care? Are they participating? How do we do that? So here they're going to be much more definitive because they don't just say the patient will participate, but it says be informed about and consent to refuse care in advance of treatment. And then it goes on to say completion of the comprehensive assessment. So use those words with the patient. I'm going to do a full assessment of you today. Care furnished based on the comprehensive assessment. Establishing and revising the plan of care, the disciplines that are going to furnish care. So I'm telling the patient about all of this, how often the visits are going to be, so a calendar, something like that. The expected outcomes, what are your goals for them? Ask them for their goals. What are the anticipated risks? What are the benefits? Any factors that could impact the treatment effectiveness. So, of course, when we talk about that our goals are to get their blood sugars within normal range, and here's the things that can impact those goals. They should receive all services outlined in the plan of care, address confidential record and HIPAA references, be advised to the extent for which payment for the services are expected. So this is something that should be updated along the way. We do it at the start of care, but along the way, if anything changes, be sure you're updating those forms. Number 8, receive proper written notice. Of course, we have the forms to do that. We have the ABN, the HHCCN, and the Notice of Medicare non-coverage. And the last 4 patient rights that are in those very well-defined, the home health hotline, which used to be its own standard, now it's here. That the patient is going to be advised on contact info, including names, addresses, and telephone numbers of other agencies, and we're supposed to provide that. So something we could do now is get busy making a list of who would be helpful for us to be able to provide for patients, and maybe putting a resource page together for the patients. And we could actually start giving that to them now in their admission pack currently. Be free from any discrimination or reprisal. That's already a current standard. Be informed of the right to access auxiliary aids and language services. So that's, of course, new too. So, after each section, we're going to go through what does this mean to me. So here's our first what does this mean to me. I've mentioned a few along the way, but we know that forms will have to be updated. We'll have to, if this goes final, we'll have to add the phone number and the name of the administrator. We'll have to add those phone numbers for the community services. So as I mentioned, you might want to gather that information now and have it on the handout currently. Add to the admission pack an overview of policies regarding admission, transfer, and discharge. I find that one unique. They want our patients to know what are your policies regarding acceptance of patients, basically. Plans and processes for language preferences. What are you going to do about this? Do you already have like an AT&T or some other sort of dial-in that you use? Plan a process to provide the plan of care copy to the patient. I'm sorry, I think I skipped over that when I was talking about all of the rights regarding being involved in the plan of care. They actually have in the proposal that we will provide that plan to them. Probably easiest is just giving them a copy. Giving them a copy of that plan of care. How are we going to do that? And then lastly, we're going to have to do some education internally. We're going to have to make sure that our staff understand about patient competency. They understand about the patient's right to choose their representative as long as they are competent, about our complaint process and policy that we already have, and any signs or symptoms of abuse, neglect, and what's our policy about reporting that, because we all should be mandatory reporters. Standard D under patient rights is the transfer and discharge. And this goes on to say that the patient and their representative have a right to be informed of our policies regarding the admission, transfer, and discharge. And we only would be transferring or discharged if the patient's goals are met, or they require another level of care, if we have no payment, if they refuse care, or the patient wants transfer or discharge, of course. We can discharge for what they call cause. And that's typically that the patient still meets the qualifications of the benefit, but for some reason our agency has chosen not to continue to see them. This could be that they're disruptive, that they're abusive, that's uncooperative, that the home isn't safe. But we would have to advise the patient and physician of the plan. And what are our efforts to resolve these problems prior to the plan? It'd be great to see documentation about that. And provide the patient with contact information for other agencies or providers. I know you're all smiling right now thinking you've got that one patient who you have discharged and you'd love to get someone else's name, wouldn't you? So yes, we're supposed to actually provide those things when we're discharging for cause. We can also, of course, discharge for death and if we would cease to operate. So that's all under transfers and discharge. So this brings us back to what do we do? What does this mean to me? Staff education on our policies for current discharge planning. That's a must-do now. Make sure we're all in the same boat already, and we all know what are our own internal policies. The documentation of the plan and attempts to rectify this issue anytime you're discharging for cause. So again, if this is our own choice as an agency, we definitely want to ensure that we've done everything we can, even including things like working out a contract with the patient. So that way you can show that there was no, we didn't just abandon the patient. There was no abandonment. We tried to rectify the issue. It was not working, and so therefore we, with proper notice, discharge the patient. We also will provide an agency contact when we discharge for cause, other agencies, and of course that notification has to be documented. We'll give that notice of Medicare non-coverage anytime this is regarding things like homebound, goals met, not medically necessary anymore. And if it is for cause, we'll give the HHCCN, or the Home Health Change in Care Notice, because we don't want to provide for the right to appeal. The NOMNIC gives you the right to appeal. We don't want this appealed, so that's the HHCCN. Standard E, this is also under patient rights. We have investigation of complaints. So we have to report to the agency administrator, and the agency has to investigate, document those actions to resolve, and actions to prevent. And here's the types of complaints that they're concerned about. Allegations reported by patients or representatives of patients regarding mistreatment or neglect, and of course any sort of abuse or injuries of unknown source or misappropriation of any property of a patient. And then we would certainly report to the authorities as necessary. Well, that wraps up patient rights. As you can see, it has expanded. Even though it's the same number of standards, lots of more detail, lots more information there. Let's move on to 484.55, the comprehensive assessment. So we currently have 5 standards here, and we're going to only go to 4 for the proposed. But don't get too excited because, again, they actually have expanded the content in here. It's just shrunk down to 4 standards is all. So right now we separate the initial and the comprehensive assessments. We've got the drug regimen review as a separate standard. The update of the comprehensive assessment, which is our resumption of care, our restart, gives us all our time frames for those. And then lastly, the integration of the OASIS. Now, in our proposed standards, they kept the content basically the same for the initial and the comprehensive. That talks about the time frames. When does it need to be done? 48 hours and 5 days for the comprehensive. Now, Standard C is the one that grew a lot. Standard C is the contents of the comprehensive assessment, and it is there that we include our current Standard C and E. The drug regimen review has been put in here. The OASIS integration has been put in here. And then they give very specific content instructions as to what has to be included in our comprehensive assessment. Standard D remains primarily the same. It's all those time points. When do we have to update the comprehensive assessment? But there is a nice change that we'll revisit here in a moment regarding the resumption of care. So our current standards B and C, as I mentioned, we talked about the comprehensive assessment. It mainly just talks about that we're going to be determining eligibility, and it has to be done within 5 days, and it has to be an RN if there's nursing orders. So pretty basic, not a lot of detail there. Now in Standard C, the drug regimen review, there is quite a bit of detail. So highlight this for yourselves now. Be sure that your forms or your software support you, that you're documenting on each and every one of these components. Potential adverse effects, drug reactions, ineffective drug therapy, significant side effects, interactions, duplicate drug therapy, and noncompliance. So I'm sure most of us are running our med list through a software and it's spitting out a report to say these are those interactions, and we're reporting that off to doc. That's a great start. But look at all the rest of this. We have to document if the meds are working or not, if there's any side effects. We need to document duplications, and that's not just duplicates of a chemical class, but if the patient has multiple meds they're taking for cardiac disease, multiple meds they're taking for pain, it's going to take the nurse to be able to look at those and, of course, then document them, because softwares don't typically do that level of detail. The new standard, as you can see, has been expanded quite a bit, and it combines that entire drug regimen review standard that we just looked at, the incorporation of the OASIS data set, and then look at the additional information about what should be included in a comprehensive assessment. It has the patient's current health, psychosocial, functional, and cognitive status. So you want a full 360 of the patient. Then it talks about what are their strengths, their goals, their care preferences, including any information that can be used to demonstrate the patient's progress towards achievement of the goals identified by the patient, and measurable outcomes identified by the agency. So again, asking our patient what their goals are, it's not just a best practice anymore, but it's going to be mandated. Number 3, the patient's continuing need for home care. Why do they need us? That's going to be great for medical necessity. And then their medical, nursing, rehabilitative, social, and discharge planning needs. It goes on. Number 5, a review of all the meds, and there's our paragraph. That's the same. Number 6 actually addresses caregivers in the comprehensive assessment, which we do, but now it's actually in the language of the COP. Number 7 talks about the rep, and number 8 is actually finally the OASIS. That it has to be integrated in a meaningful way, and it can't just be stapled at the end or left to the end of your software. So the pain items have to be in the pain assessment. That wraps up our comprehensive assessment, except for the update, standard D, our last standard here. The time frames are the same. They're the same for the other follow-up, or our SIC, as you might have called it, significant change of condition. They're the same for recent, and they're the same for discharge. But here's the improvement that I mentioned that we may see if this passes for the resumption of care. Right now, there's no regulatory allowance for us to have a doctor's order to extend when we do our resumption of care. Meaning, if a patient comes home on Friday from the hospital, we have to be out there within 2 days. By Sunday, I have to be out there in order to be compliant. Even if the doc says it's okay to go on Monday, even if the patient requests to go on Monday, of course I'll go on Monday, but I'm out of compliance with the regulation. In the proposed rule, they're now saying they'll allow a physician-ordered resumption of care date as an alternative. So as we do right now at start of cares, we have the option of going 2 days from the referral date or on a specific day that the doc says to go. We're looking at having the same thing for the resumption of care, which would be great. So what does this mean to me? Review the current comprehensive assessments. Right now, you'll want to take a peek at your own assessments and make sure that you are already doing a lot of these things, which I think you are. Do they meet all those criteria? And I think the OASIS helps. The OASIS really does give us that full 360 view of the patient. It includes psychosocial, it includes the caregiver, it includes all that stuff. So I think that's going to help for sure. And if not, you might want to look at different forums or talk to your vendors right now as far as are they prepping for that. Review your own current policy on comprehensive assessments because we want to make sure that you do have a policy, first of all. And do you have a policy? The part that we usually get caught on is, do you have a policy about the other follow-up? The other follow-up is done when we see that significant change in condition. If the patient's had a major decline or improvement that we didn't expect, then we want to make sure that there's a policy that we should do the other follow-up comprehensive assessment. So those of you who are OASIS geeks, you know Mu 100, it is going to be a number 5 there that says other follow-up. Right now, I want to remind staff that we have to do our resumption within 2 days, within our 48 hours. And we're going to review those processes for our current resumption of care and update our policy if this does go final, that we allow for that extension if that happens. But we don't know if that's going to happen right now. The next COP is that one that has been merged together with acceptance of patients in the plan of care. Again, that's our number one citation, and it's because of the plan of care piece and the coordination of patient services. So those two have now been merged into one COP with 5 different standards. And of course, the COPs at the top of the page, the care planning, coordination of services, and quality of care. And then down below, you'll see those 5 standards. The plan of care that were in sync with the physician's orders, that we're reviewing and revising that plan of care on an ongoing basis. We're coordinating care, and lastly, the discharge or transfer summary is also talked about here. So we saw that back at patient rights, and then we're going to see it here because the coordination of care piece. So let's look at Standard A, the plan of care. So all of these at the top of your slide are all the same. This is mandated to be in our plan of care. Most of us use the 485, so that keeps us on track, and we all can be ensured that we have these pieces. Excuse me, but the two at the bottom that are bolded for you, these are new. And the first one says that the patient and caregiver education and training are documented that we have facilitated timely discharge. So we're not just laissez-faire. We are working towards the goal of discharge, working towards getting that patient and or caregiver to be more and more independent here. The second one says patient-specific interventions and education. So that I think most of us have in our plan of cares. Measurable outcomes and goals identified by the agency and the patient. So again, asking our patient for their goals, making sure all of our goals are measurable. So I want to step back and give an overall view of this piece. We're maintaining the acceptance for patients based on that we think we can meet this patient's medical, nursing, rehab, and social needs just on an intermittent basis at home. So there's the level of care we're talking about. They also maintained our plan of care standards with a few new criteria. So I do underline our new criteria. So, well, actually all of these are the new ones. Education to the patient and caregiver to ensure timely discharge. Again, something that I think we're all doing now, but now it needs to be documented because it's actually in the COPs. Ensure it's clearly documented that the patient was included in the goals. So you want to have a shared decision-making model here. The one that's underlined here, bullet 3, providing a plan of care to the patient and updates that plan of care in writing. So providing the copy, I don't think that's going to be too hard. But to be able to keep that updated, that's going to be a tricky piece, isn't it? I don't know if we're going to bring out copies of orders, or this is just going to be one that you're going to have to think about. So as far as what to do now, just start thinking about it. I wouldn't implement any of this. I'm not completely sold that this part's going to stay. I think there's going to be a lot of comments about this. The plan of care needs to be understandable to the patient, they're saying, because, of course, if that's what we're providing to inform the patient, then they have to be able to understand it. So if that's true, think of how different our plans will be written. So again, nothing I would change right now, but I do like that you might want to start thinking now about clarity of your plans of care anyway. Not that you're going to take out the jargon and things like that at this point, but I still think we sometimes have a long ways to go on how can we really show the focus of care in a clearer manner in that Locator 21. Ensure that clinicians are aware of barriers. Are we sensitive to think about what types of things could be impacting this patient's overall health care? Different types of family dynamics or other sorts of socioeconomic factors. Are we paying attention to those things? And then lastly, they mentioned that we have to provide a re-hospitalization assessment, which you actually have a very short version of right in your OASIS. But here's the key. We also then have to provide interventions to mitigate this risk for the plan of care. So, what can we do differently in our plans of care? That's what does it mean to me. Look at your plans of care right now. Again, are they understandable? How can we make them clearer? And we'll just be thinking about if it passes that we have to provide this to the patient, how are we going to do that? The training of staff regarding health coaching. So getting on the same team as the patient rather than just teaching, which can be taken as condescending sometimes. So health coaching is the buzzword, isn't it? So trying to be more inclusionary with the patient about their care and goals. That's what we're going for. Training of staff to identify risk factors. So again, not just going through the motions, not just checking a bunch of boxes, but really being very aware during our assessments as to what's going on with the patient. I have given you a URL. There was a lot of talk in these proposed COPs about being sensitive to underserved populations. And so this URL was provided in the proposed COPs and, of course, has a lot of information about different things we can do to assist the underserved even better. And then, as we mentioned, how are we going to logistically even provide that plan of care and keep it updated? The next standards B and C, is conformance with those physician orders and review of those orders in the plan of care. So the first one, standard B, conformance with the orders, that didn't change, except it does say that verbal orders have to be signed, dated, and timed. Next one says that we are going to review and revise the plan of care, and those revisions to the plan of care have to be communicated to the patient, the caregiver, and the physician. So we should be doing that right now. The plan of discharge has to, again, be communicated to the patient, the caregiver, and the physician. Again, things we should be doing, but now they're actually in the standard. Excuse me. Standard D, coordination of care. So this is the integration of the services in an interdisciplinary way. We're planning that care, communicating with the physician, carrying out that plan. And the key is to get it documented, isn't it? Because we have this current standard, but documentation is always more. The agency also must ensure that the patient and caregiver receive ongoing education and training regarding care and services on the plan of care. So I think we do a good job of this. That is, it's the second top thing that we do in home health. The first one is assessment, second one is teaching. But you certainly want to now tie this so we can show that the education is provided and aimed to, again, discharge timely. Are you catching some trends here? Standard E talks about that discharge or transfer summary. So the summaries have to include not just why they're leaving now, but it is a true summary. The summary must include the patient's stay and a full summary about that, including the reason for the referral to the agency, the patient's clinical, mental, psychosocial, cognitive, and functional conditions at the time of admission. So I think a good idea would be to make sure that we document this clearly, maybe some sort of narrative way at the beginning of care. And if you're using your narrative to corroborate the physician's visit for your face-to-face, this might just be an opportunity to copy and paste. We could say, patient status at start of care, copy and paste that. And then we could talk about what services were provided by us, and the start and end date of the services, and now what do they look like. What's their clinical, mental, psychosocial, cognitive, functional condition at the time of discharge? Otherwise, I just think we're going to miss that piece, because this is a lot. This is a much more extensive summary than what we've been doing in most cases. You can see that this has really grown as far as what we may have to do. So again, be strategic on how are we going to accomplish this. I think we have to be doing discharge summaries now. I would start doing at least a good exercise on what did we provide, the start and end dates, what do they look like now, and any recommendations for ongoing care. Now, they are also going to mandate that we are going to include an updated reconciled list of meds at the time of discharge or transfer. Many of us who are already accredited already have to do this. I was just at an agency yesterday who is accredited with HCS-D, and that was actually a problem that they found is when they did a transfer, they didn't do a complete summary that it didn't include their meds. So be sure that you're also looking at your own policies currently, and if you're accredited, those standards also. So those of you who are accredited, a lot of this stuff has already been done due to those additional quality standards that you're already having to abide by. It has to also include the current plan of care, including the latest orders. Look how big this is getting. This is a multi-page transfer or discharge summary, that's for sure. And any other documentation that's going to assist in the continuity of care. And of course, that's a little bit open for interpretation. So look at what you're doing currently. Does your EMR assist you in putting this together? What do your forms look like? And you can choose to adopt a transfer summary currently, right now, as a best practice. And again, many of us, our standards already mandate that we do this. Again, best practice to provide that med list anyway. So that wraps up our combined COP there about patient care and plan of care, et cetera, and coordination of care. Next, we're going into one of the brand new COPs, and that's, of course, the COPs program. So we've got 5 standards here: the scope, the data, the activities, the performance improvement, and then what are the executive responsibilities. So under our current quality guidelines, we are told to have this group of professional personnel and provide an evaluation of our agency yearly. And really that is just more of a summary and a reaction. Very intermittent, it's very problem-oriented, and they're proposing to delete both of those COPs. Excuse me. The new proposal, of course, just says quality assessment, performance improvement, and again, the focus is ongoing, real-time, data-driven, and to be proactive. So if we see we have any risks, we're going to address those risks even before they become a problem. So Standard A defines the scope. They talk about that it should be measurable improvement in selected quality indicators, and we'll talk about what those quality indicators are. There needs to be evidence that improvement with this quality indicator will improve health outcomes, such as decreased hospitalization, safety. The agency has to measure, analyze, and track these quality indicators, and will want to include adverse effects or adverse events and other aspects that assess processes, services, and operations. Standard B talks about the data. So if the scope just gives an overview, the data goes in and says, we need to utilize those quality indicators, and whenever we can, we'll use the things that are very objective, like OASIS and other relevant data that can be objective. That data should be focused on those high priority safety and health conditions. And those goals are going to be identified by you as an agency. And the data is collected to monitor the effectiveness of your quality of care, identify opportunities for improvement, and You'll want to ensure that you are taking this data to the governing body because they're the ones who are supposed to approve the frequency and the detail, both, of your data collection. Now, COPs is supposed to, program activities standard C. So we know about the data. Now here's what we're going to do with it. We're supposed to focus on either high risk or high volume and problem areas. So those areas where we know patients are at high risk, if you have some issues with wounds or IVs, things like that, or what do you do the most? That's our high volume. You'll consider the incidence, the prevalence and severity of issues, and you make an immediate correction when the issue threatens health and safety of patients, of course. Otherwise, we're going to track and analyze and implement those preventative actions for any adverse effects in more of a systematic way. And how can we show then, by measuring in that data, we have had success and that our improvements are sustained? Standard D talks about performance improvement projects. So before we talked about activities, which kind of lends itself to these projects, but Standard D goes into more detail about just the projects. And we're supposed to conduct projects at least annually and include projects that touch to all pieces of our agency, not just patient care, but we're going to do a 360 view of our agency and see where do we need to do some performance improvement. It should reflect the complexity of our agency and our past performance. And we're going to be looking for those areas that maybe we've had poor outcomes or, again, we know is a high volume risk. So the example here for wound care, if you are someone, or I think IVs would actually be a better example of something you do very, very rarely. If you don't do wound care very often, it's not high volume, but it's certainly high risk. Maybe wound vacs. Maybe you don't do wound vacs, but maybe once a year. That is a high risk area. How are we going to keep people competent in between there? Or if you're an agency who has a lot of wounds, then that's also an area of risk because you have so many patients that certainly we're going to have an error here or there because just the number of incidents we have. So we have to document that project, the reason, and the progress we've achieved on all of these interventions. The umbrella over all of this is the governing body, and I think this is difficult, especially for my friends who are at hospital-based agencies, because many times the governing body doesn't want to be this involved. But it is in the regulation. They do need to be involved with our COPs program. We have to report these things to them, and we really hope they give us some feedback. So this might be an area that we start building some bridges and letting people know we're going to be speaking with them more coming forward. So the governing body is responsible to ensure that your program is defined, implemented, and maintained. So certainly that's just reporting off to them that you've got the program, what your PIPs are, and that's an ongoing basis. But look at the second bullet. The governing body is supposed to be addressing priorities and ensuring that our efforts are prioritized in our COPs program. They're helping evaluate effectiveness. We are looking at expectations for patient safety and that we're establishing those on the front end and implementing and, of course, maintaining those, and, of course, addressing any potential findings of fraud or abuse. So where do we even start right now? What does this mean to you right now? I would look at beginning your own just mini model of a COPs program if you haven't already done so. Review how are you currently performing PI? How are you currently looking at your needs? I expect that there's someone at your agency who's printing off those CASPER reports at least quarterly, and you're looking at your outcome-based quality improvements, your OBQI, your outcome-based quality monitoring, your OBQM, your process-based measures, that's your PBQI. But there's also a couple other great reports you'll want to take a peek at. The patient-specific characteristics report is a reflection of who you are, what types of patients you have, when do they end up in the hospital, when do they end up needing the ER. All of that is in there. We can start working on those things right away. Become familiar with and start adopting tools provided out there for free that you could help hopefully improve those outcomes. So look at those reports. I'm sure you're already doing this. And then take advantage of that, homehealthquality.org. They have several programs out there for CHF, COPD, diabetes, pain, and I encourage you to take a peek at those and use those. So what does this mean to me? Well, the first thing I wanted to highlight is we want to get started on the QAPI process now, because it is something that will benefit you and your patients even right now. And it's something that I think we're halfway doing. Again, we're looking at those reports, but what are we doing next? Most of the time we just say, we've looked at it, we've confirmed it is an OASIS problem, or we've confirmed it really was a problem. But what do we do next? Can we ask ourselves, are there plans we can move forward on now to implement changes to protect patient safety and try to decrease the incidence of this problem in the future? And I think it's important not only from a good patient care perspective to get going on QAPI now, but because this is going to be a hot topic for scrutiny. Since this is new to us, and the surveyors are getting geared up for it now, and many of our surveyors do both home health and hospice, so they know the QAPI program. We know that this is an area that they're going to be looking at. So I just cut a couple of quotes out here for you from the proposed COPs regarding the surveyor activities. So just a quick overview so we can start thinking, letting those wheels turn about QAPI. Remember, the quality assessment is the collection of data used both clinical and non-clinical operational areas. So think about things like, how timely is your documentation getting done? That's not really clinical, it's operational, it's systems. And use that data to track your quality over time to see where are we at. The performance improvement piece, use other benchmarks or internal targets that you have to say, this is where I'd like to be. So, for example, on any of those outcomes, we have the state average and the national average, so we have those benchmarks. For our timeliness, we might have a policy, and if we're not even meeting that, then that's what we want to work on. And we're going to take action whenever that performance falls below that target for 2 periods or more. So we're only going to do that from doing quality assessment. So whenever we fall below, it wasn't just a fluke, that we've got something going on, then we're going to implement a PIP. We need to do a performance improvement project. How do you select your measures? Well, that's up to you as a QAPI team. But again, it should be based on data. You should have a rationale for each measure. Why are you tracking this? What are you going to do with the information? And again, consider those industry-vetted measures. Wanted to give you just some resources because I know you're going to have those wheels turning about this. So your data sources for QAPI, just that industry-wide, what we should have, I've included here for you. Patient chart, the OASIS with the OBQI, OBQM, the patient-specific characteristics report, looking at why do they always end up in the hospital? Why are they always in the ER? Any incident report trends you find, any infection report trends you find. But even look at your satisfaction surveys. Are there any trends? Your billing. Are you taking longer to get your wraps out than you used to? Or where are you at in that process? What about your finals? Are you having problems getting back your signed documentation from the doctor? Financial reports and your complaint logs. Those are all great areas that we can look for data. We have to ensure, though, that when we use this data, we want to know that this was systematically collected, that it's done the same way every time. And again, remember that when we talk about data collection, we want to get this approval, include it in your report to the governing body, and in the minutes that you did talk with them about this. Using the data, again, is for actionable reporting. And boy, it is so nice to have a visual, isn't it? So this is just a reminder to get out those little Excel skills or have someone that does have those skills, and be sure that you're tracking and trending over time, or you're looking at yourself compared to benchmarks. And if you can create a visual to show where we've grown or where we're sliding, that will be very helpful, especially when you're reporting this to the board. And identify those opportunities for improvement. So if you see that there's a gap between the actual performance and desired performance, that's an area where we want to look into. Survey deficiencies, if it's areas where maybe just management wants to improve a process of communication, of our timeliness of documentation, and ask for suggestions from your staff. What would you like to see get improved? Are there other things that we can include here? So really hone in that this is not just patient outcome. Certainly we want a lot of it to be patient outcome, but it's also other things. That performance improvement project should always be conducted by a team and include all relevant disciplines. I like to have everyone at the table and have different people that work on the different projects. So you'll have a team, you'll investigate the cause for why do you think this outcome is lagging, what's going on, and then you'll develop and implement a plan for improvement. And I always think it's great to pilot test that with just a few small cases. Do a beta test for a limited time, see if it's actually working, and then we'll push that program out in a bigger way then. And of course, documentation. Those abbreviated tips, when you just have a small problem, we can do an abbreviated tip using a smaller team, and we can review the literature or best practice information out there from that quality improvement organization, our QIO for us. We'll write that plan and implement it, and we can just monitor results for 1 or 2 months rather than waiting for a whole year. So it's like testing the hypothesis. You think this is the issue. I'm going to put these measures in place to try to resolve it. Let's see what happens. And if it works, fantastic. If it doesn't, you can continue to tweak at that to make sure that you do get a better outcome. So here's an example of an agency who wanted to look at their completion of documentation and employee turnover. So you can see how they graphed out these areas, and these were what they were going to then work on. They had to drill down to say, well, what's causing these problems, and then what can we do about them, and see if that would work. Well, take a breath. That wraps up COPs. We're going to move to the other COP that is brand new, 484.70. This is infection prevention and control. So the agency, you have to maintain and document an infection control program which has a goal for prevention and control of infections and communicable diseases. 3 standards under this: prevention, control, and education. So most of us who are already accredited, we're already doing these things. So you should have your own policies about your standards of practice, your standard precautions, your policies regarding hand hygiene, bag technique, all of that good stuff. But then we need to, under control, be doing surveillance. So are we reporting infections patients acquire or even our staff acquire? What is our role in preventing that infection? What is our role in investigating? This is a key piece to our quality program. If we can see that there's a lot of infections, can I tie that to one nurse? Can I tie it to one type of infection? And making sure that we're providing education to staff, patients, and caregivers. So that's all, again, in this last standard here, standard C. So what does that mean to you? Well, again, this won't be new to any of you who are accredited. But the rest of us, you may want to start looking at how are you going to track infections if you're not already doing this. And if you're doing that piece, are you doing something with the data, or is it just kept in a book? So look at how you would actually analyze that, look for any trends, and make sure we're updated with the current best practices when it comes to infection control. So I've given you the CDC website there at the bottom, and again, that's great for patient education also. They have a lot of good stuff out there about hand hygiene, blood glucose monitoring, etc. So making sure we're all up to date with those things. Also under patient care, this is a current COP we have, skilled professional services, but as you can see right now there are 3 standards: skilled nursing, therapy services, and medical social services. All have their single standard. They all have their own standard. But the proposed COP is putting all of these into one pot, calling it skilled professional services. So now these have become standards instead of separate COPs. So see how it used to be 44.30, 0.32, and 34. Now it's just going to be 44.75 with A, B, and C. So there's just one condition to cite on, but we will have the 3 standards. So they have the provision, they have the responsibilities of skilled professionals, and supervision. But all of the skilled services, nursing, therapy, and medical social workers are all under here. So under Standard B, because A didn't have a lot new, so under Standard B I want to highlight a few things. Assuming the responsibility for ongoing interdisciplinary assessment and development of that individualized plan of care. So that's what we do. Providing the care per that plan. That's what we do. Providing the patient, caregiver, and family counseling. Now that's new. We don't have that in our current standards. Same with providing the patient and caregiver education. That's new also. Of course, the documentation is already a standard we're including. But then it goes on to talk about communicating with the physician who's responsible for that plan of care. We do that. It hasn't been stated quite like this. And then it talks about participating in our quality assessment and performance improvement program. The QAPI has come back to haunt us again. It is woven throughout here. So again, it talks about QAPI even when I'm talking about responsibilities of the nurse, therapist, and social worker. When we get to supervision, under Standard C, it says that an RN identified by the agency has supervised the care by an LPN or LVN. So they're a little more clear here. Most of us are going under our state regs, but now they're giving us a little more push about this. They still don't provide a time frame, though. It does talk about therapy assistants that can be supervised by professional therapy assistants, and of course the same thing with our MSWs. So not a lot of changes, even though it's a huge change in the structure of going from having nursing, therapy, and social worker COPs under one professional service COP. Home health aid services, 44.80. So as you can see, lots of standards under here. We're not going to go through each one, but I want to give you a high-level overview. Overall, most of the standards are retained. They're mostly the same. There's some nice clarifications. There's some reorganization. And they do incorporate the personnel qualifications that are currently in 44.4. It does separate out the organization and the instructors in 2 different standards, and it separates out the competency evaluation and in-service into 2 different standards. So again, not a big deal there. It's just a reformatting, if you will. It does add, though, that there needs to be communication skills under the content of the training to include that aide's ability to read and write and verbally report clinical information to the patients, the representatives, the caregivers, as well as agency staff. So they did add that as well as they added that the aid training on a mannequin can be done, but also it says to conduct a competency evaluation on the, quote, pseudo-patient. And it says, however, the pseudo-patient for the competency eval would have to be an individual, such as another aide or a volunteer, whose age is representative of the primary population served by the agency. So that's not most of us. So we'll have to be thinking about how are we going to handle that new twist. So there's a new skill requirement related to recognizing and reporting change in skin condition. So with the focus on pressure ulcers across the whole continuum of care, they're really focusing in even on the aide's role of doing this. And again, they're saying we need annual on-site, which most of us are doing, and they even emphasize that the aide should be part of our interdisciplinary team. That brings us to our last subpart. So the last subpart, organizational environment, I've provided the COPs for you. Not a lot of changes here. The first one, I wanted to give you the standards in that in the governing body, they do designate that this is full legal authority. Now, this can be just one person. If you're the owner and you're the it, you can be one person. The administrator has to be available during operating hours, and you do have to have someone in line to take your place in case of an absence. So be sure that you've reported that to your state even. The clinical manager, they've revised this to state that it has to include such hands-on supervision that even making patient personnel assignments, or at least you're overseeing it, coordinating patient care, referrals, they want this clinical manager at the ground level, don't they? They want them seeing and knowing these patient-nurse relationships or the patient-clinician relationship. They do define that parent-branch relationship a little bit more here, as they did in the first section, and then they talk a little bit about services under arrangement, that when we are contracting with others, we still maintain the professional liability. So we need to get everything we would as if they were an employee in that folder in the HR. So what does this mean to me? Well, do you currently have any drop sites? And if you do, what's your plan for these? Do you need this as a branch? And if you have a branch, make sure it's acting like a true branch that is independent, but the parent company has to be involved enough that you can show it's maintaining that day-to-day oversight. And do you think your clinical managers are involved in that clinical oversight as the proposed COP describes? So it might be good to go back and look at our current job descriptions and what's really going on with our clinical managers at this time.